So now we'll be starting with the radiology part of today's grand test. So the first question was a 3-week-old infant underwent sonography. So the keywords I'll highlight, it is an infant. Okay, so we are talking about a very young onset kidney disease. 3-year-old infant underwent ultrasound of the abdomen which revealed a small sized right kidney with the presence of multiple enlarged cysts, and the left kidney was normal. So it is a unilateral disease. Subsequently, he went renal DMSA scan. Now, renal DMSA scan is done for looking at the scars, okay, for looking at renal scars. And what did it show? It showed increased tracer uptake on the left side and minimal uptake on the right side. So it means that the right kidney is non-functional, right? The right kidney is non-functional. So we have a unilateral non-functioning right kidney with multiple cysts within it in a 3-week-old neonate, right? So what will be the answer to this question? So answer here would be a multicystic dysplastic kidney because it is favoring the age. MCDK is seen in prenatal period as well and in neonates, right? Now, autosomal dominant polycystic kidney disease, ARPKD. Now, these are usually not non-functional. Usually, the kidney has some preserved function, and the difference between these two is the age of onset. So, ADPKD is seen in adults, and ARPKD is seen in children. Right? Now, pelvic-ureteric junction obstruction in children is a congenital variety. It is a congenital problem in children and it has a hydronephrosis. It does not have cysts within it. It has hydronephrosis. So, let's look at the various images of these. So, the first image here is that of ARPKD. And what do we see here? We see that there are these multiple small cysts scattered throughout the kidney and the kidney is enlarged, and you see that there is no corticomedullary junction. So what have I said? There is no corticomedullary differentiation. The kidneys are enlarged and there are multiple tiny cysts. Multiple tiny cysts are there. Okay, and the renal echogenicity is also raised. Renal echogenicity is also raised. It is appearing more bright. So these are features of an ARPKD patient and these are typically seen in children. Whereas an ADPKD, the second image here is that of an ADPKD, and what do we see here? We see that the bilateral kidneys are enlarged. So the first criteria is bilateral enlarged kidneys. Okay. Now, what else do we see here? We see multiple large cysts, okay, multiple large cysts as compared to tiny cysts in ARPKD. And also we see that there are associated liver cysts, okay. So, liver cysts along with bilateral kidney cysts are seen in ADPKD, whereas in ARPKD, usually congenital hepatic fibrosis, berry aneurysms, these are the things that are seen in ARPKD. Now, both ARPKD and ADPKD are bilateral diseases, whereas multicystic dysplastic kidney and PUJ obstruction are usually unilateral disease. Whereas in PUJ obstruction, what will you see? You will see hydronephrosis. So, this image is that of a PUJ obstruction in which you see that there is hydronephrosis within the kidney, but the ureter is not dilated. So, there is hydronephrosis, but ureter is not dilated. Okay, so how do you differentiate between hydronephrosis and cysts? So, hydronephrosis has intercommunicating cysts. So, you will see that these areas are communicating with each other. So, that means they are not cysts, but that they are part of the pelvic calyceal system. So, that is how you differentiate between a cystic disease and a PUJ obstruction. Now, this typical third image here is that of a MDCKD, MCDK, multicystic dysplastic kidney, and you see that the right kidney is small and there are multiple these cysts and large cysts replacing the entire renal parenchyma, and such kidneys are usually non-functional. So, the answer here is a multicystic dysplastic kidney. Now, we move on to the next question. A 51-year-old male underwent contrast-enhanced CT of the chest and abdomen for generalized weakness and vague abdominal pain. Now, the reporting senior resident asked the junior resident about the attenuation values of different materials on CT. So we want to look at the HU values. How do we look at the attenuation values of materials on CT? By Hounsfield unit, or we call it HU value. HU value, right? And the question is asking us to arrange them in decreasing order. So whichever has the large maximum HU value, we'll put it first. Now, what are the various HU values of different materials on a CT? So if we draw a line, if we plot every attenuation values of the common materials on CT in a line, we take the reference value of 0 HU as water. Okay, and in this side and in this side, we'll keep objects which are bright or have high attenuation values, and on this side, we'll keep objects which have low attenuation values, or they'll appear black. Okay, so the highest attenuation values are that of metals. So for example, if iron metal is there, it show very streak artifacts. So they have very high attenuation values. So around 400 to 800 HU, we have cortical bone. Okay, very high attenuation value, appear bright. Then around 200 to 400, we have calcifications. Now the more common soft tissues, that is liver, spleen, pancreas, they have an attenuation value of 30 to 50 HU. So these includes liver, spleen, muscles. Okay, these are, we'll commonly club them under soft tissues. Okay, and remember, we are talking about attenuation values on a non-contrast CT. These are HU values on an NCCT, right? Remember this point. Now, the darker objects, darker than water, are fat and air. These two things you have to remember, which appear black on CT. So what is the typical attenuation value of fat? Usually minus 40 to minus 100 HU, and air has an attenuation value of minus 1000 HU. Okay, so given the question, if you want to arrange them in decreasing order, what will be the answer? So the maximum attenuation value will be that of bones, followed by liver, followed by water, followed by fat, and then followed by air. So the answer here is option number B. Okay. Now let's move on to the next question. A 75-year-old male, so it is an elderly male, fell down the stairs. So it is a trivial trauma. Okay, and sustained a head injury. Now in a head injury in an elderly more than 75, yes, we'll go ahead and do a NCCT head. And what does the NCCT head shows? So look at this image right here. So this is a non-contrast CT of the brain. We see this hyperdensity along the right frontoparietal convexity. And what type of hyperdensity is it? It is showing this convexo-concave shape. It is like a convexo-concave shape, and it is crossing this frontoparietal suture. So what have we learned here? So it is an acute bleed, yes, because it is appearing hyperdense. So it is an acute bleed. Its shape is concavo-convex. It is crossing the sutures. Okay, and it is occurring in an elderly male with a trivial trauma. So yes, you guessed it right. The answer here is a subdural hematoma. Anything else that you want to comment on this CT clinically? Suppose you are sitting as a radiologist in trauma center and you're given with this CT. So I think almost everybody would recognize that it is an FTH, but the thing that you have to mention in the report is the midline shift. Very important clinically, midline shift. Okay, so you draw a line from the center and then measure the deviation of the septum pellucidum from the midline, and if it is more than 5 mm, it is an indication for emergency decompression. So the answer here is a subdural hematoma. Now how does an EDH and an SAH looks like? So an EDH typically will have a biconvex margins, but not necessarily true. And its usual location is that in the temporal lobe. Temporal lobe has a biconvex margins, right? And it does not cross the sutures. It does not cross the sutures. Okay, and if you're given in the history a lucid interval, okay, or a high velocity trauma, or there is an associated fracture of the skull, so the chances of it being a EDH is much more common than it being an FDH. Okay, remember, for brain hemorrhages, the shape of the bleed is not so important, but the crossing of the suture, crossing of midline, associated skull fracture, trivial trauma, high velocity trauma, these are much more important things differentiating between an FDH and an EDH. Now, SAH has a sulcal, it has bleed in the sulci, brain sulci, or the cisterns. Okay. Now, remember, regarding SAH, most common cause of SAH is, yes, trauma. But if you're asking the question, most common cause of non-traumatic SAH, a non-traumatic SAH, the answer there will be berry aneurysms. Berry aneurysms. Okay. Investigation of choice in a non-traumatic SAH. In a non-traumatic SAH, investigation of choice to identify the cause. To identify the cause, if this is asked in the question, or if you are given in the question that patient has an SAH, no history of trauma, what will be the next line of management? Then you will go ahead and do a CT angio of the brain to identify these berry aneurysms. And for a non-traumatic SAH, the gold standard is DSA. Okay, so this was a brief capsule about the various intracranial hemorrhages, very important topic as far as your entrances exams are concerned. Now we move on to the next question. A child presents with cyanosis. Okay, so we are talking about cyanotic congenital heart disease. Okay, and if you remember my lecture, if you remember my talk on cyanotic congenital heart disease in cardiovascular radiology, you'll get to know that I have divided them cyanotic, CHDs. The next step that you have to ask, if you see a question in which there is a cyanosis that has been asked, to look at the lung fields. Okay, then in the lung fields, what do we see here? We see that they are appearing black. There is not much increased vascularity that we see here. Okay, the pulmonary vessels don't go till the peripheral 1/3 of the lung field. So it is a case of pulmonary oligemia. Okay, so the pulmonary blood flow here is reduced. Now, what was the other end of the spectrum in a cyanotic congenital heart disease, in which the pulmonary blood flow was increased? So, in this case, we are dealing with a reduced pulmonary blood flow. Now, what are the two possibilities in a cyanotic congenital heart disease with reduced pulmonary blood flow? Number one is TOF, and number two is Epstein's anomaly. And how will you differentiate between the two? You just had to look at the cardiac size, heart size. Okay, if the heart size is normal, the answer will be TOF. If the heart size is increased, the answer will be Epstein's anomaly. Okay, I do not want to give you typical named signs of various congenital anomalies, because that is not how you approach a question. That is not how you approach an X-ray. So I want you to learn how to approach an X-ray of a congenital heart disease. So this is an algorithmic flowchart on how you approach a cyanotic congenital heart disease. Now, in this given X-ray, we have provided that the child has cyanosis, the pulmonary blood flow is reduced, and the heart size is normal. So answer here will be TOF. It is a TOF tetralogy of Fallot. Now, in TOF, what happens? The heart size is normal, but the right ventricle hypertrophy is there. So the cardiac apex is turned upwards, and this is what gives a typical boot-shaped heart. Okay, boot-shaped heart is due to right ventricular hypertrophy. Now, remember the other three options that are given: cottage, loaf heart, truncus arteriosus, TAP PVC, and TGA. All of them have increased pulmonary blood flow, right? So, these all are fitting under increased pulmonary blood flow. Okay. So, what is the algorithm that we mentioned? First, in a cyanotic congenital heart disease, you look at the lung fields. Okay, if it is an reduced pulmonary blood flow, there are two options, TOF and Epstein's anomaly. If the heart size is normal, the answer is TOF. If the heart size is increased, the answer is an Epstein anomaly. Okay, let's move on to the next question. So, a 60-year-old postmenopausal woman visits her family doctor with concern about her condition of her bones. She wants to determine her own risk because osteoporosis runs in her family. Although she has never broken a bone before, she is concerned about her bone density. She has a history of smoking and follows a sedentary lifestyle. Her BMI falls within healthy range. Which of the following investigations can be used to investigate her for osteoporosis? Now the options given are a multiple choice question, 1, 2, 1, 2, 3, 1, 2, 3, 4 or 1, 3, 4. So it is not a single best correct option. So we have to look at all the modalities which help us diagnose osteoporosis. Okay. So this is how you approach a question. This question does not ask you the best investigation or the investigation of choice for a DEXA. So which are the investigations which help us evaluate osteoporosis? So DEXA is definitely one. DEXA is the investigation of choice. And what do you see in DEXA? How do you use DEXA? You evaluate the T-scores. We'll come to T-scores in a bit. Now, in radiography, can radiography be used? Yes, radiography you see compression fractures, right? And quantitative CT. Now, what is quantitative CT? So, DEXA, we know that it measures the bone mineral density. And quantitative CT is another type of CT. There is a special software which is used to analyze, but it is also analyzing the bone mineral density. So quantitative CT is also the correct option here. Okay. Now chemical analysis in a primary osteoporosis is usually normal. Okay, it is usually normal in a primary osteoporosis. So the answer here will be 1, 2 and 3. The DEXA being the investigation of choice, it helps us calculate the bone mineral density, and below which T-score do we say that it is osteoporosis? Less than minus 2.5 standard deviation. If the T-score is less than this, then we call it osteoporosis. Between minus 1 to minus 2.5, we'll call it osteopenia. And if the bone mineral density is more than minus 1, it is normal. Okay. Now on radiographs, what do we see? We see typical compression fractures. So if this is the normal vertebra height in osteoporosis, what will happen? There will be compression fractures. There will be wedge compression fractures of the vertebra, and in advanced cases, there can be a vertebra plana. Okay, vertebra plana can also occur. Now we move on to the next question. It is a direct one-liner question, and these type of questions are asked in FMGE exams too. So champagne glass pelvis is seen in. It is a direct one-liner answer. No concept here. The answer here is a achondroplasia. Now champagne glass pelvis is due to a narrow flat iliac bones. So this is how pelvic iliac bones look in an achondroplasia patient. Now let's just discuss the other options also. So DDH, what will be the imaging findings? So typically the femoral head lies in the inferior-medial quadrant. So what are we talking about? So we draw two lines. This is known as the Hilgen-Renus line. So we draw two lines in the pelvis to locate the femoral head. Okay, and the femoral head lies in the inferior-medial quadrant. Now in DDH, what happens? There is flattening of the acetabulum, right? So the femoral head dislocates posterior superiorly. So this is one of the signs of DDH, and also the Shenton's line is broken. Another is breaking of Shenton's line. Okay, so this is the Shenton's line that is normal present. It is broken here. The femoral head is dislocated superiorly, so there is breaking of the Shenton's line. Now the second image is that of a Perthes disease, and Perthes disease is a very important question for an entrance exam. Now Perthes disease is typically bilateral, and it is an idiopathic osteonecrosis of femur. Okay, we know that femoral avian has a lot of risk factors like steroid use, sickle cell anemia, and etc. But if it is due to idiopathic cause and it is occurring in a children, so then we call it a Perthes disease. Now, in Perthes disease, since it is an avian, so there will be destruction and flattening of the femoral epiphysis. We see that the femoral epiphysis is destroyed, but the joint space in an early disease is maintained. Okay, the joint space is maintained. So these are the findings of Perthes disease. Now the third image that we see here is that of osteogenesis imperfecta. And what do we see here? Imperfecta. And what do we see here? We see these multiple fractures involving the lower limb bones. Okay, so it will be a neonate in which there are multiple fractures of various ages involving the multiple bones of the body, and these are the characteristic of osteogenesis imperfecta. Okay, now we move on to the next question. A 45-year-old man arrives at emergency room complaining of vomiting, nausea, and excruciating abdominal discomfort. So usually now the trend is that long questions will be asked in FMG because the pattern is almost similar to that of an ionized CT or a NEET VG. So be ready to answer the long questions. And now long questions you have to read fast, keep underlining the key points. So we are talking about an emergency case and an acute abdomen. Okay, so this history tells us it is an acute abdomen case. He has a long history of alcoholism. Physical examination reveals patient's upper abdomen is painful and tender. Serum levels of amylase and lipase are increased. So we are talking about acute pancreatitis, and the patient has been identified as having acute pancreatitis based on clinical presentation and test results. He receives conservative treatment, however, he experiences severe stomach pain during his hospital stay, and an imaging was done. Right, so what is the most probable diagnosis here? So these are the following options that are provided to us. So first of all, the question directly mentions acute pancreatitis is the diagnosis. So the other two options will directly rule out. So we want to differentiate whether it is a pancreatic pseudocyst or a walled-off necrosis. Now in this image, what do we see here? We see that there is a homogeneous collection. It is a homogeneous collection, that is, it is appearing similar density throughout, and it has a wall, it has a capsule, it is a capsulated collection. So remember, in a acute pancreatitis collection, if it is occurring, if the time has elapsed more than 4 weeks, or if it has developed a capsule, okay, so an acute peripancreatic collection or an pancreatitis collection after 4 weeks with a capsule can either be a walled-off necrosis or a pseudocyst. Now, how do you differentiate? It depends whether there was necrosis or not in the initial scan. Now, we haven't been provided with the initial scan, but this collection that is provided to us is appearing very homogeneous. So, it is a pseudocyst. It is a pseudocyst. Now, walled-off necrosis has a collection which has heterogeneity. It is heterogeneous within. Okay, I'll show you an example. But remember, in an acute pancreatitis patient, when will you do a CT? First question, the CT is done at day 3 to day 5. Why? Because during this time, the necrosis is best seen. Now, if there is presence of necrosis is present, so it will be an acute necrotizing pancreatitis. But if the necrosis is absent, then it is acute interstitial pancreatitis, right? And the pancreatic collections that form in these two types of pancreatitis are different. Okay, so if an necrotizing pancreatitis has a collection less than 4 weeks, we call it acute necrotic collection. But if the 4 weeks have elapsed, then we call it walled-off necrosis. However, in an acute interstitial pancreatitis, the types of collections less than 4 weeks are acute peripancreatic fluid collection, and more than 4 weeks, it is pseudocyst. Okay, so these are the various type of pancreatic collections in an acute pancreatitis case. Now, wall of necrosis and pseudocyst have a difference, that since wall of necrosis has necrosis within, so it appears heterogeneous. So this is how a wall of necrosis looks like. Okay, so it will have a capsule around it, but you will see these dark areas within the collection. They represent necrosis, whereas an acute necrotic collection does not have any wall around it. Okay, but it is again appearing heterogeneous because of presence of necrosis, whereas acute peripancreatic collection does not have a wall around it, and it appears as this thin streak of fluid around the pancreas. There is no necrosis that is present here. Okay, so I hope various collections of acute pancreatitis were clear now. Now, decreasing order of radiosensitivity among the given tissues and organs. So this is again memorizing question, nothing great concept here. So remember, most radiosensitive organ is bone marrow or gonads, both. Okay, most radio resistant is the nervous tissue, so brain. Now, if we are asking about the most radio resistant organ, then the answer is a vagina. Okay, and regarding the blood cells, which is the most sensitive, radiosensitive blood cell, it is WBC, and radio resistant blood cell is platelet. Okay, so in the decreasing order of frequency, which is the most sensitive, we've just talked about bone marrow, and which is the least radio sensitive, that is radio resistant, it is the brain. So the answer here will be D. Okay, nothing much concept, you just have to memorize this. Okay, now we move on to the next question. A 60-year-old male with a history of hypertension presents with progressive dyspnea on exertion, chest pain and syncope. Physical examination reveals a harsh ejection systolic murmur along the right upper sternal border. Now, ejection systolic murmur is characteristic of aortic stenosis, right? A decreased carotid pulse and a delayed peak femoral pulse. Which imaging technique is regarded as the gold standard for evaluating the severity of the condition mentioned? Now, it is an overlap between medicine and radiology and more of a medicine question per se, but let's just discuss it here. So, aortic stenosis which is the gold standard for evaluating severity, it is echocardiography, because we want to measure the Vmax, aortic area, aortic isthmus area, annulus area, aortic valve area, and the pressure gradient. Okay, all these are measured on echocardiography, and that is used to assess the severity of the condition. So now we move on to the next question. Identify the correct match about various iodinated contrast agents. So again, a memorizing question, no greater concept here. So urographin. So first, urographin is an ionic contrast media and it has high osmolality. So it is a high osmolar contrast agent. Then ioxaglate. So ioxaglate is again an ionic contrast agent, but it is a low osmolar contrast agent. So this is a third option. Now iopamidol is a non-ionic low osmolar, okay, non-ionic low osmolar contrast agent, and iodixonol is an iso-osmolar contrast agent. So the answer typically here would be D. So A4, B3, C2 and D1. Now remember, iodixonol is an iso-osmolar contrast agent, so it has an osmolality around 270. Whereas a low ionic osmolar agents have typically osmolality between 600 to 800, and these are the most common. These are the most common contrast media in CT. Okay. Now, urographin is used in fluoroscopic images, fluoroscopic studies. For example, if you are doing MCU, if you are doing RGU, sometimes in barium swallows also. swallow, contrast swallows. Okay, so these are used in fluoroscopic studies typically. So this was about the radiologic questions discussion from this grant test. Thank you.